We will proceed to the next session, which is actually one of the most important topics for the society. We are discussing about randomized controlled trials, and actually we are in the process of publishing results to the biggest trial ever in the topic. 1,057 people randomized into conventional versus MiECS systems with COMICS trial, which will be presented to you by Professor Antonitsis. And of course, the trial that has succeeded this MiECS trial, which we have now, as you will see, 130 patients out of 1,300 that is designed to have, that is 10%. So both of them are, for us, very important to give evidence, because after this we will have class 1 level of evidence A, and that would give maximum input that we could give as society to people that they need data. So sufficient data is there, and I hope we will be able to accomplish both of these goals in the next couple of years. So John, yes. You present polychronis and take it from here.
Yes, so I think now I have Professor results from the sorry, thank you. Yeah, so Professor Antonitsis will be giving us an overview of the results of the COMICS trial and a preview of the upcoming MiECS trial.
Okay, thank you very much for coming and joining MiECS anniversary meeting. So I would like to show you the transition from COMICS to MiECS. Okay, so COMICS at first was a large randomized trial that was designed in 2017. The first patient was recruited on May 8, 2018 in Thessaloniki. These are the landmarks. 14 centers participated. It is the largest study on cardiopulmonary bypass. And actually COMICS was launched after the position paper produced in 2015 by the society, by the MiECS, actually defining what is minimal invasive extracorporeal circulation. This was a multi-center effort, a multidisciplinary effort, and this position paper was actually proposed by surgeons, by anesthesiologists, and by perfusionists. So the conditions were mature, the conditions were ready to really perform a study on minimal invasive versus conventional cardiopulmonary bypass. It was designed the protocol was designed by Bristol. The aim was to test the hypothesis that MiECS is effective and cost-effective compared to conventional extracorporeal circulation to most cardiac surgery operations. And actually, it was designed to estimate a difference in a primary composite outcome and 30 days postoperatively, and the cost-effectiveness of MiECS as well. The types were used were type 2, 3, and 4 as defined in the MiECS position paper. And also, there was something important. There was the conventional circuit was not actually conventional. We gave the opportunity to be optimized. So apart from the conventional circuit, one center could add a coated oxygenator, could add coated tubing, could add a centrifugal pump, but it was not allowed to use a soft shell reservoir or vacuum-assisted drainage, because these components actually make conventional resemble to minimal invasive extracorporeal circulation. So it was real world. The primary outcome was composing of 12, let's say, hard endpoints: death, MI, intubation, tracheostomy, gut infarction, prolonged mechanical ventilation, stage 3 acute kidney injury, stroke, reoperation, need for coronary for percutaneous coronary intervention, sternal wound infection, or septicemia. And secondary outcomes were blood products transfused, ICU and hospital stay, other serious adverse events, and quality of life. So the statistical sample analysis showed that in order to have a 90% statistical power, we had to randomize 3,500 patients to detect a difference in 25% in the primary outcome. The expected rate of the primary outcome was 15 to 18%. And we were expecting a reduction of 25% in the minimal invasive extracorporeal circulation cohort. So through these years, we managed to randomize 1,071 patients with a rate of about 25 to 30 patients per month in the good months. And this was actually related also to the COVID pandemic that actually exerted a very, very great pressure to the study. Also, what we saw is that the primary outcome rate, as I told you, instead of 15 to 18%, it was around 10%. So these are the final arms of the COMICS study. 536 versus 535 patients were analyzed for the primary and secondary outcomes, and the result was that there was a significant 25% reduction in the incidence of the composite primary outcome. So as you can see, this was statistically significant with a p-value of 0.025. Combining all-cause mortality, serious adverse events, and all the events that comprise the primary outcome. Regarding the other outcomes, there was no statistically significant difference, either in ICU stay or hospital stay. And if we see the numbers, then we find that the primary outcome event was 13.2% in the conventional extracorporeal circulation cohort versus 9.7% in minimally invasive extracorporeal circulation, which gives a statistical significant difference. We calculated red blood cells in terms of patients transfused and not in units transfused. That's why there was no difference in patients in the rate of patients transfused in both arms, either in red cell transfusion or in other blood product transfusion. Otherwise, regarding the quality of life, there was statistically significant difference in terms of the visual analog scale, EQ5D score. Okay, so at 30 days and at 90 days, minimally invasive extracorporeal circulation, let's say, was really associated with a significant improvement in quality of life. There were some issues in this study that need to be addressed and have been extensively discussed. First of all, regarding the arm of minimally invasive extracorporeal circulation, a significant percentage of patients randomized to MiECS did not receive the alternative allocation. The analysis is always intention to treat. So even if you receive an alternative allocation, the statistical analysis needs to include you to the arm that you have been initially randomized at. So these patients were randomized as MiECS and analyzed as MiECS. There were some other deviations from the protocol. I mean, 9 out of 500 patients, a roller pump was used with MiECS, which is actually a deviation because MiECS should include a centrifugal pump. Also, we found that in patients randomized to minimally invasive extracorporeal circulation, a huge proportion of patients had the cardiotomy suction used. So there was actually a mixture of shed blood to the circuit that actually makes the circuit not completely, not 100% closed. And also, you can see that COMICS trial produced a significant difference in the need for transfusion intraoperatively. So 21.7% of patients in the conventional extracorporeal circulation required the transfusion intraoperatively, while 12% of patients required an RBC transfusion intraoperatively in minimally invasive extracorporeal circulation. But as I told you previously, the total incidence of patients transfused was not statistically significant. And this was because there was not a uniform blood transfusion protocol. So that means that within the next postoperative course of the patient in the ICU, there was, let's say, a diffusion, a minimization of this optimal outcome produced during surgery, okay? So as the centers had a liberal protocol of transfusion, this led to a total of patients transfused, the total rate of patients transfused to be the same, while there was significant difference in the patients transfused intraoperatively. Regarding the primary outcome events, we will see that with minimally invasive extracorporeal circulation, the rate of the primary composite outcome was low, but it was actually minimal. So it was 0% stroke, it was 2.5% of reintubation as compared to 5% in the conventional arm, and also the incidence of sternal wound infection or septicemia was actually very, very low as compared to a higher result as related to the conventional extracorporeal circulation. So this study has important strengths and important limitations. The strengths are important. The study is pragmatic. There are different minimally invasive extracorporeal circulation systems. It's real world, and it is compared actually to optimized conventional cardiopulmonary bypass and not the standard cardiopulmonary bypass. It is a multi-center study. It is a clinically important primary outcome, and also it addressed all limitations of previous randomized studies that were not considered, that were considered to have a significant risk of bias. So actually, all measures to avoid bias were taken for this study, and avoiding bias is a significant strength of the study. The limitation is that the planned sample size was large, and it could not be achieved during the COVID period. So with a statistical power of 90% during the COVID pandemic, in order to randomize 3,500 patients was not possible. We also found a reduced incidence of primary outcome. If the incidence of primary outcome was 10% instead of 15 or 18%. So this says that the surgery, let's say, was better than expected. Yes, that's correct. Maybe 85% of cases were coronary cases, so there should have been a mixture of more difficult cases in both the conventional and the minimally invasive extracorporeal circulation arm. Second, optimized extracorporeal circulation was used in a significant proportion of patients, okay? So including centrifugal pump, coating, and cell salvage was used in a significant percentage of conventional extracorporeal circulation. Also, perfusionists followed goal-directed protocols that, let's say, reduce the incidence of adverse outcomes. And regarding the secondary outcomes, as I told you, the analysis of blood transfusion was based on blood products used. So even if one patient received 1 unit of blood one night in the ICU by the attending physician, this patient would count as having a blood transfusion at the same level as the one who had 10 units of blood transfused. So we didn't focus on volume or units of blood, but we focused on either the patient was transfused or not. And this actually underestimated the benefit that we have found on the intraoperative use of blood products. Okay, so the intraoperative benefit, the benefit was lost. And also, as Dr. El-Essawi is always pointing out, using a cardiotomy suction and mixing and said blood with the circuit, you actually lose this closed circulation, this closed physiology benefit of minimally invasive extracorporeal circulation. You increase the possibility of having a systemic inflammatory response, and this correlates with outcomes that are related to systemic inflammation, like atrial fibrillation, and also it relates to blood transfusion and all that. This study, I believe that within the next month will be published in Perfusion Journal, and we will have the time to discuss it further in multiple instances. So now we're in a crossroad. What shall we do? Is it better to stop? It's always better to shine a light than curse the darkness. So it's always better to do something rather than do nothing. Okay, so there is no need to curse the results rather than learn from them, but we need to avoid using the same old thinking because we will produce the same old results. And as El-Essawi and Einstein telling, it's not good to do the same thing over and over and expecting different results. So from comics, MiECS study was born. Okay, so it's a randomized controlled trial that, let's say, follows the same pathway, but addresses main limitations of comics trial. So first of all, we need to all agree with this thing. Conventional cardiopulmonary bypass, we can never say that conventional cardiopulmonary bypass is not safe and effective as MiECS. In the real world, conventional cardiopulmonary bypass with, let's say, the Quantum heart-lung machine or the Livanova Essence heart-lung machine is absolutely safe and effective in performing all types of cardiac surgery. So this is a fact. What are we aiming to do? And this is reflected in evidence-based guidelines concerning minimally invasive extracorporeal circulation. We want to make it more physiologic to reduce the incidence of adverse complications. So is MiECS a better perfusion technique compared to conventional cardiopulmonary bypass? In which terms? In terms of reducing the incidence of perfusion-related complications and not surgery-related complications, as it is the postoperative myocardial infarction. If you have, let's say, a compromised, not so meticulous technique in coronary surgery, a graft failure, then you will have an MI. So it's not related actually to perfusion. So we will test the same hypothesis again, that compared to conventional cardiac surgery, minimally invasive is effective in reducing a primary outcome, that this time the primary outcome consists of hard endpoints, death, type 5 MI, stroke, but also acute kidney injury of all stages, not stage 3, that is hemodialysis. All stages acute kidney injury. Mechanical ventilation for more than 48 hours is a very delicate marker, and it's considered by the STS as a marker of something that happened during surgery, rate of reintubation, of course, rate of reoperation, and septicemia confirmed by microbiology. While secondary outcomes will include blood products transfused per unit, not patients transfused, blood products transfused, incidence of postoperative atrial fibrillation, ICU and hospital stay, other serious adverse events, and health-related quality of life. Why any stage acute kidney injury is important? It is important because even if you see studies evaluating studies that evaluated outcomes after cardiac surgery, like the Title II trial, which focused on blood transfusion after cardiac surgery, you can see that during cardiac surgery, we can expect a rate of at least 14% of any stage acute kidney injury. Okay, so this study that consisted of 40% coronary cases, at least a 14% of any stage acute kidney injury was evidenced during cardiac surgery. And even in the ARC trial that actually compared a single mammary versus bilateral mammary in coronary cases, you can see that the most frequent complication was acute kidney injury that was found in 17.4% of patients. Okay, so this is an incidence that is related to perfusion. Why it is related to perfusion? Because if we see the results of Ranucci's GIFT trial, goal-directed perfusion, he found that with goal-directed perfusion, with the optimal perfusion strategy in terms of providing metabolic substrate to the tissues, what he could find, and he included 24% CABX patients, was that the main difference was reflected in the acute kidney injury of any kind. So in the arm not using goal-directed perfusion, he found a 25% incidence of acute kidney injury, while in the patients that he did goal-directed perfusion, as is the case in our study, because as you have shown in the previous study, the centers used delicate perfusion, optimized perfusion circuits, and optimized perfusion techniques while randomizing patients. So he found with goal-directed perfusion an incidence of 15.4%. So we actually included any kind of acute kidney injury as a primary outcome in our study, and we opt for including 50% of coronary cases and 50% of aortic valve cases or combined cases in order to increase the complexity of the surgery and not including, let's say, straightforward coronary cases. And with having an 80% statistical power and expecting an outcome with very, very, very conservative estimation of 20% of the composite outcome, you saw that acute kidney injuries from 15% to 25%. So expecting a 20% incidence in conventional extracorporeal circulation, expecting for a 30% reduction in primary outcome, we need now to randomize 1,300 patients for the study in 2 arms of 650 patients. How can a center can take part? A center can take part if using MiECS for 50 or more operations, operations of the type of which participant is being recruited, and this is the learning curve. So the learning curve for MiECS is 50 patients. Eligibility criteria are very, very liberal. So actually, patients could be randomized if they are over 18 or less than 85 years old, mainly without having an emergency surgery or aortic surgery or or having a hematology disease that could actually mix the result and, let's say, underestimates the benefits of minimal invasive extracorporeal circulation. Trial intervention will be the same. So actually, optimized conventional extracorporeal circulation will be accepted. Okay, so coated oxygenators, coated tubing, and centrifugal pump could be integrated into the conventional circuit. Full sternotomy, surgeons must use the same body temperature and cardioplegia solution. And also, let's say, learning from comics, we applied a transfusion threshold. So we applied a transfusion threshold either intraoperative directed perfusion intraoperatively, a DO2 index of less than 2.80 or an oxygen extraction rate of more than 40% gives the perfusionist, let's say, the signal to transfuse the patient. So as far as today, we have recruited 130 over 1,300 patients, and this makes a 10% incidence, and 40 patients were recruited from Thessaloniki, 31 from Ulm, 10 patients from Bari, and 49 patients from Izmir, Turkey. And the case mix, the same again. Most cases are coronary cases, and we expect to have more valve, aortic valve, and combined cases in the future. Is it feasible? It's feasible if we increase a little bit the recruitment rate. So if we manage to do at least 30 patients per month, it is feasible within 3.5 years to conclude the study. I believe we can achieve even for more. The study is not designed by Bristol, it's designed by Aristotle University Clinical Trials Unit, and the major investigators, apart from Professor Anastasiadis and me as a study coordinator, it's Andreas Liebold and Prakash Punjabi, Sardar Gunaydin, Asraf El-Essawi, Cyril Serik, and every sender is allowed to be registered as an investigator in the study. It's important that we have with us clinical dendrite system registry, which is a very, very experienced and very, very easy to use registry to put the patient data in. It takes about 20 minutes to get the patient's data in, and it's simple. It's the perioperative 30 days period with data that you have inside the notes or in the clinical system of the hospital. You don't need writing at all. There is a trial steering committee with the president of John Murkin and data monitoring committee with professors from our university. This is very, very experienced committee. And for the time being, you see the 4 centers, but I hope that Toronto, it's Brian here, will start soon, Ankara, Papworth, Hammersmith, and Hull, Braunschweig and Göttingen from Germany, possibly Coswig, Ancona with Dr. De Usanio and Pietro Malvidi, and possibly Regensburg could contribute with cases. If we achieve 10 or 12 centers, that would be great. So the message of this presentation is join us if you can. If you cannot, try to change something and join us as well. Okay, thank you very much for your patience, for your attention.
Thank you very much. And I think the panel will be making some commentary on the results.
Let's start one comment each because we don't have that much time. So all together, either for comics or for MiECS, a comment from all the panel. There is online commentators as well.
Well, I only have one comment. I think that one problem in doing a large prospective randomized trial in such a setting is that you have to get a lot of participants into the boat. That leads to the fact that you make some compromises. I think that we have learned a lot from the experience of the comics trial, and I hope that this will reflect in a more powerful MiECS trial.
So we really need large data to publish and to increase the level of evidence or the class level in guidelines. So this will be a very good opportunity. in Turkey, as Youssef presented before, in the last year after COVID, there was a time that we couldn't even find the oxygenator. So people were forced to use MiECS. So this was not a voluntary choice, but so that's why there were 18 centers and now 8 centers, but still we need to motivate them. So I believe Istanbul is also going to participate. They're doing nearly every case by MiECS.
Yes, I believe that it is really important to collect the data, analyze the results of MiECS. I believe that it is important improve the post-operative management of the patients undergoing the MiECS. That I think that the principal limitation in the hospital today is that there are low allied professionals with high turnover in the management of the healthcare of the patients. It's possible to see that anesthesiologists in the middle of the night change the protocol. I believe that only one limitation is that improve the post-operative practice in the MiECS strategy. But nevertheless, I think that is a good way in my perspective.
Thank you, Brian.
So we are about to start participating in Toronto. Speaking to a surgeon before I left, actually, and we have our first few patients kind of lined up for the 3-week out mark. So we're about to start performing the trial on them. It'll be interesting to see if we can stick to that transfusion trigger. To Ashraf's points, there's a lot of hands in the pot when you do a big trial like this. So I think it might be difficult to stick to the transfusion trigger. Is there a way that in the dendrite system that we're able to audit that, like when a transfusion is given, if it adhered to that trigger?
Yes, of course, you can actually have a liberal policy on transfusion. We will record that. Okay, so you're free to transfuse, but try to keep the protocol. We record the HB level when transfused, but we try to keep it at a level of 8. Otherwise, the results are largely diffused. So you see that we lost a significant advantage of reduced intraoperative transfusion by letting 14 centers transfuse without having a certain, very, very liberally. Okay, so we will record it, you will record it, and possibly in a secondary analysis, we will say that we will see whether this affected the transfusion rate or not. Okay.
Okay, yeah,
okay.
good.
So
we will do our best as long as we can track if there are any outliers that occur.
Narain, before you comment, there is one comment from me to you. As you know, UK is quite active in mini bypass in MiECS, and we would like to have all of you on board. Unfortunately, Prakash is not, and Alex Cale is not joining, so you are the UK representative. So I would like to say that despite a lot of efforts that Polychronis has done so far with Imperial, that is leading to have the final verdict from your, I don't know, it is an insurance issue or whatever it is, we still struggle to have UK on board. And I can tell you that Canada, as we discussed yesterday, they have the same NHS with you. I mean, the healthcare is about the same. So since you have Canada's permission, I believe that it won't be that difficult for UK to accept that insurance shouldn't be the case, because for the rest of the people that they don't know, this is not a sponsored trial. So we don't have either fund or sponsoring. And that's the issue for the UK guys that say, okay, what will happen for our patients? So Narain, Brian is here, Beairsto, and you can ask him how they managed to get the permission. So what about you? What do you think?
First, thank you. Welcome. Nice to see you all, and fantastic conference. And thank you for inviting me to talk. Specifically, just the comments on the 2 trials. The data is powerful. It's still needed to change mindset and to deliver the real change we want in clinical outcomes. So fantastic results from COMET's MiECS trials still needed. I echo the points that have been made already about learning, transfusion requirements. The patients are allocated one onto the other is a big issue in the use of cell suckers during the mini bypass set. and specifically the changes that outside the operating room. I think those are all crucial points, and they need to be addressed and are being addressed to make sure the trials show some valid results. To answer your last question specifically, it's not necessarily the insurance, it's the funding. Most of the departments that I've spoken to, and I've spoken to Prakash offline, Polychronius is doing a fantastic effort, and he's been pushing us all. Our department specifically, it's about funding, and I know that's the same with Prakash. And so finding sponsorship or ways around that is what we're trying to do. But because since COVID, our R&D departments are swamped with different studies, they will only take on ones that are funded, and that is the biggest challenge.
Okay, thank you, Noreen. Is there any question from the floor, because we're running a bit late? Okay, so John, would you close it with comments regarding comics and MiECS? You are the senior guy. You are the chair of the steering committee of MiECS.
Yes.
And you've been one of the authors of the comics paper. So,
well, I think, again, as we're all commenting, one of the real benefits of the MiECS trial is the fact that we have gone through a rather challenging process, as you've heard, with the comics trial. And so based on those results, we've been able to identify some of the rate-limiting factors and some of the missed opportunities. And I think the fact that we will look for rifle 1 criterion, so changes in creatinines and renal performance, rather than having a hard endpoint of dialysis. I think, again, what we're trying to do is identify changes in organ function. So rather than waiting for an extreme endpoint such as dialysis, in fact, we can have a more sensitive measure. And similarly, the big confounder of patients having no real adherence to the restrictive guidelines for postoperative transfusion also confounded the results. So I think the ability to focus on these aspects and hopefully minimize them in the upcoming trial are important learning factors. So.
Okay. So thank you all for this session. I hope we'll be able to publish very soon, maybe next month, and you will have the full paper. And we are proceeding for the next session, which is the mix on MiECS with Vadim and Ashraf.